Hello students, let's study herpes virus. So there are three families, alpha, beta, gamma. So alpha duration is short, 12 to 18 hours, cytolytic, site of latency neurons, species, herpes virus 1, human herpes 2 and 3. So human herpes 1 is herpes simplex virus type 1, human herpes 2 is the herpes simplex virus type 2 and 3 is varicella zoster virus. Beta is the long duration of replication and cytopathology, that is more than 24 hours, and it is cytomegalic. So the site of latency is glands and kidneys. So it is officially it is herpes 5 and the common name is cytomegalovirus. Then long duration more than 24 hours, the cytopathology is lymphoproliferative. The site of latency lymphoid tissue T cells. It is 6 and then 6 type and then common name is herpes 6. Human herpes 6. Human herpes 7 is human herpes 7. The gamma family variable duration of replication and this cytopathology is lymphoproliferative, and then lymphoid and tissues B cells is the site of latency, and it is human herpes 4. The common name is Epstein-Barr virus, and human herpes 8 it is Kaposi sarcoma associated herpes virus. Morphology of herpes virus. Herpes viridae comprises of group of viruses that possess a unique property of establishing latent or persistent infections in their host, undergo periodic reactivation. Size large, 150 to 200 nanometer size. Then shape spherical with icosahedral symmetry. Linear double-stranded DNA comprising of 125 to 140 kbp. Nucleotide surrounded by capsid composed of 162 capsomers. Enveloped lipoprotein in nature, lipid part derived from the nuclear membrane, protein part virus coded, glycoprotein spikes about 8 nanometer long are inserted into lipid part. Tegument, amorphous, sometimes asymmetric structure present between capsid and the envelope. Pathogenesis. Transmission occurs through abraded skin or the mucosa. Site of infection. HSV replicates at the local site of infection and produces less commonly. HSV1 lesions are confined to areas above waist, common site around mouth. HSV2 produces lesions below waist, most common site genital area. Spread via nerve. Virus then invades local nerve ending, transported by retrograde axonal flow to the dorsal root ganglia, replicates further, undergoes latency. Primary HSV infections are usually mild, mostly asymptomatic. In immunocompromised hosts, viremia occurs that lead to widespread organ involvement and systemic manifestation. HSV has a tendency to undergo latency in neurons. So HSV1 trigeminal ganglia, HSV2 sacral ganglia. Non-replicating state. HSV does not replicate in latent stage except for small RNA called microRNA encoded by a latency-associated viral gene, which maintains latent infection and prevents cell death. Viruses cannot be isolated during latency. Reactivation of the latent virus. Following fever, axonal injury, physical emotional stress, and exposure to ultraviolet light. Via the axonal spread, virus goes back to peripheral site and further replicates in skin or mucosa and produces secondary lesions. Recurrent infections are less extensive and less severe because of presence of pre-existing host immunity that limits the local viral replication. Many recurrences are asymptomatic, but viruses are shared in the secretions. Clinical manifestations. HSV1. Orofacial mucosal lesions, most common affected site, buccal mucosa. Most frequent primary lesion, gingivostomatitis and pharyngitis. Most frequent recurrent lesion is herpes labialis, painful vesicles near the lips. Other lesions, ulcerative stomatitis and tonsillitis. Many cases are asymptomatic but can predispose to secondary infection by bacteria such as Streptococcus and Pneumococcus. Cutaneous lesions, herpetic whitlow, febrile blisters, herpes gladiatorum, eczema herpeticum, erythema multiforme. Visceral and disseminated herpes. Risk factors: immunocompromised patients, underlying malnutrition or AIDS, pregnant women, and transplant recipients are at a high risk of developing viremia and disseminated infection. Common manifestations: pneumonitis, tracheobronchitis, hepatitis. Ocular lesions, HSV1 is more common than HSV2. Severe conjunctivitis, most common manifestation. Nervous system, encephalitis, meningitis, other manifestations, autonomous nervous system involvement, sacral region, transverse myelitis, Guillain-Barré syndrome, peripheral nervous system involvement, Bell's palsy. Clinical manifestations, HSV2, genital lesions. HSV2 is more common than HSV1. Bilateral painful multiple tiny vesicular ulcers associated with fever and inguinal lymphadenopathy. Neonatal herpes, transmission during birth from maternal genital tract, in utero or after the birth. Risk of developing neonatal herpes is maximum 10 times more if the mother recently acquires virus primary infection than those who are presented with recurrent infection. HSV2 is more common to cause neonatal herpes, 70% of the cases. Clinical features, babies are almost always asymptomatic and presenting one of the three forms. Local lesions involving skin, eye and mouth. Encephalitis, disseminated disease involving multiple organs, including CNS. Neonate has the highest frequency of visceral infections. Laboratory diagnosis, cytopathology, Zhang's preparation by Wright's or Jimsa stain, virus isolation, viral antigen detection by direct immunofluorescence, HSV DNA detection, PCR and real-time PCR, antibody detection by ELISA or other formats. First, cytopathology. Scrapings obtained from base of the lesion can be stained with Wright's or Jimsa, Zhang preparation or Papanicolaou stain. Sensitivity of staining is low, less than 30% for mucosal swabs. Cannot differentiate between HSV1 and 2 and varicella zoster virus, as all of them produce similar but characteristic cytopathological changes such as Cowdery type A, intranuclear inclusion bodies, lip cells body, multinucleated giant cells, ballooning of infected cells, margination of chromatin. Virus isolation remains most definitive tool for HSV diagnosis. Growth inside cell lines can be detected in 2 to 4 days. Characteristic cytopathic effect. Diffuse rounding and ballooning of infected cells. Viral antigen detection by neutralization test or immunofluorescence staining with specific antiserum. Shell vial technique can be followed to decrease the detection time to less than 24 hours. Third is the viral antigen detection by direct immunofluorescence. Staining with specific antiserum, sensitive and specific, can differentiate HSV1 and HSV2. Fourth is HSV DNA detection, PCR, most sensitive, differentiates between HSV1 and 2. Real-time PCR targeting genes glycoprotein B and UL30, more sensitive, can quantitate the viral load in specimens and also differentiate HSV1 and 2. Fifth is antibody detection. Antibodies appear in 4 to 7 days after the infection and peak in 2 to 4 weeks. IgM appears first and is replaced by IgG, which persists for life. Treatment, acyclovir is a drug of choice, acts by inhibiting viral DNA polymerase. Prevention, use of condom to prevent genital herpes. Neonatal herpes can be prevented by prior administration of acyclovir to mothers during third trimester of pregnancy or delivery by elective cesarean section. No vaccine is currently licensed. Several vaccine trials are going on, such as recombinant HSV2 glycoprotein vaccine. Herpes simplex virus 1 mode, direct contact saliva. Herpes 2, sexual vertical. Herpes 1, age children. Herpes 2, adults. Herpes 1, clinical features, skin lesions above waist. Herpes 2, below waist. Herpes 1, orofacial mucosal lesions, ocular lesions, meningitis, encephalitis. In herpes 2, genital lesions, neonatal herpes. The latency in herpes 1 is trigeminal ganglia, herpes 2, sacral ganglia. Recurrence occasional in herpes 1, herpes 2, recurrence more often. Neurovirulence less and drug resistance less in herpes 1. Herpes 2, it is more. Clinical manifestation in herpes 1, lesions are thin-walled umbilicated vessels which break down, leaving tiny superficial ulcers, heal without scarring. Orofacial infections, gingiostomatitis, ulcerative stomatitis, herpes labialis, pharyngitis, tonsillitis, cutaneous herpetic vitellofebrile blisters, ocular conjunctivitis, corneal ulcers, nervous system encephalitis, meningitis, Bell's palsy. Clinical manifestation in herpes 2, genital herpes, Main commonly penis, urethra, women's cervix, vagina, vulva, perineum, macules followed by vesicular eruption, painful vesicular ulcerative lesions. Neonatal herpes may take three forms: disseminated, CNS, skin, eye, mouth involvement. Varicella zoster virus produces vesicular eruptions or rashes on skin and mucous membranes. Two clinical forms, chickenpox and second is a zoster or shingles. So chickenpox generalized diffuse bilateral vesicular rashes following primary infection, usually affecting children. Zoster occurs following reactivation of latent VZV, varicella zoster virus, present in trigeminal ganglia that occurs mainly in adult life. Vesicular rashes are unilateral and segmental, confined to skin innervated by a single sensory ganglion. Portal of entry, respiratory mucosa or conjunctiva. Spread replicates in regional lymph nodes, spills over and enter bloodstream, primary viremia. Spread to liver and spleen, multiply, again enter bloodstream, secondary viremia. VZV present in infected mononuclear cells are transported. 2. Skin virus replication in epithelial cells, rashes, swelling of epithelial cells, ballooning degeneration, and accumulation of tissue fluids result in formation of vesicles. Respiratory tract shading respiratory secretion, transmission of infection. Neurons access to neurons of trigeminal ganglia and undergo latency. Chickenpox clinical manifestations, incubation period 10 to 21 days. Typical description of rash, vesicular, centripetal in distribution, bilateral and diffuse, appear in multiple crops. Fever appears with each crop of rashes. Disease of childhood, when occurs in adults, it is more severe and with bullous and hemorrhagic rash. Most common infectious complication, secondary bacterial infection of the skin. Most common extracutaneous complications, CNS involvement. Cerebellar ataxia, encephalitis, aseptic meningitis, usually in children. Most serious complication, varicella pneumonia, develops more common in adults than children and particularly severe in pregnant women. Ray's syndrome, other complications are myocarditis, nephritis, corneal lesion, and arthritis. Zoster or shingles, due to reactivation of latent varicella zoster virus in old age, more than 60 years of age, in immunocompromised individual or occasionally in healthy adults. Starts with severe pain in area of skin or mucosa supplied by one or more groups of sensory nerves and ganglia. Rashes are unilateral, segmental, confined to area of skin supplied by affected nerve. Most common nerve involved, ophthalmic branch of trigeminal nerve. Head, neck, and trunk are the most common affected sites. Complications: post-herpetic neuralgia, zoster ophthalmicus, Ramsay-Hunt syndrome, visceral disease. Laboratory diagnosis, cytopathology, Giemsa staining of scraping from the ulcer base. Jang smear reveals cytopathological changes similar to that of HSV infection, such as formation of multinucleated giant cell. Virus isolation in various cell lines can also produce HSV-like cytopathic effects, diffuse rounding, ballooning of the infected cells. Specific methods include specific antigen detection by direct immunofluorescence staining, PCR detecting VZV specific genes. Varicella zoster virus, primary infection varicella, chickenpox, reactivation zoster or shingles. Varicella is the primary disease in non-immune person, while zoster is the recurrent form and occurs in older or immunocompromised patient. Lab diagnosis: specimen, vesicle fluid, skin swab, scraping from the lesion, saliva, CSF. Microscopic examination, Jang smear, stain with toluidine blue O, Jang cells, multinucleated giant cells, nuclei homogeneous, ground glass chromatin. Giemsa stain, intranuclear Cowdery type A inclusion body. Electron microscope, virus particle demonstration. Vaccine, live attenuated vaccine using OCA strain of VZV available. Given to children after 1 year of age. 2 doses. First dose at 12 to 15 months and second at 4 to 6 years. Also given to seronegative adults, 2 doses at 1 month gap. Transmission of the vaccine virus can occasionally cause mild rash in the recipient. Protectivity: vaccine more than 80% effective in preventing chickenpox in children, but less so in adults. However, it is 95% effective in preventing severe disease. Infection control measure, isolation, airborne precaution, negative airflow room, plus contact precaution must be followed until lesions are dry and crusted. For localized zoster, it is an immunocompetent host. Contact precaution alone can be followed. Cytomegalovirus, largest virus in herpes viridae family, named because it causes massive enlargement of infected host cell. Clinical manifestations: congenital infection, perinatal infection, infection in immunocompetent, infection in immunocompromised, and transplant recipient. Congenital CME infection, most common intrauterine infection associated with the congenital defects, may develop significant psychomotor, hearing, ocular, or dental defects within 2 years. Congenital defects include: most common defects are petechiae, hepatosplenomegaly, and jaundice. Less common include microcephaly, cerebral calcifications, intrauterine growth retardation, and prematurity. Risk is maximum if the infection occurs in early pregnancy and if the mother is primarily infected during pregnancy. One-third of primarily infected mothers transmit virus to fetus, in contrast to 1% of reactivated mothers. Perinatal CME infection transmission to newborn occurs either during delivery through infected birth canal or postnatal through infected breast milk or secretion from mother. Mostly asymptomatic but shed virus in urine from 8 to 12 weeks of age up to several years. Few infants, especially premature babies, develop interstitial pneumonitis. Laboratory diagnosis: detection of inclusion bodies in urine, characteristic perinuclear cytoplasmic inclusions in addition to usual intranuclear inclusions seen in other herpes. So it is called owl eye appearance. Virus isolation, throat washings, and urine. Human fibroblasts are the most ideal cell line. Cytopathic effects after 2 to 3 weeks of incubation. The typical CME inclusions: multinucleated giant cells are seen, enlargement of infected host cells seen. Shell vial technique useful in CME mononucleosis where the viral load is low and CP takes several weeks to appear. Antibody detection by ELISA method. CME IgM antibodies appear in 1 to 2 weeks after infection, indicate recent or ongoing infection. In pregnancy, it indicates congenital infection, guiding initiation of appropriate treatment. CMV IgG antibodies are produced few days after IgM and persist for long, indicate either recent or past infection, which can be differentiated by performing IgG avidity test. Low IgG avidity indicates recent infection, less than 3 weeks. Is also useful in diagnosing congenital infection. Antigen detection: CME specific PP65 antigen, major matrix phosphoprotein, can be detected in peripheral blood leukocytes by indirect immunofluorescence test using specific monoclonal antibody. Test has been used since long but less preferred as it is time consuming and technically demanding. Molecular methods: PCR to detect specific CME DNA in blood and body fluids such as CSF. Various genes targeted are glycoprotein V, DNA polymerase, and PP65. PCR assays are rapid, highly sensitive, specific, and have replaced gold standard culture technique in most laboratories. Real-time PCR can quantitate viral load and method of choice to monitor the treatment response. Summary: cytomegalovirus, children, adults, inapprehended infection, clinical infants, intrauterine death, prematurity, congenital anomaly. Immunocompromised, severe local and disseminated CME disease. Post-transfusion CME mononucleosis. Adult disease: reactivation of virus acquired early in life. Fever, tiredness, and muscle pain. Lymphocyte cirrhosis with atypical lymphocytes. Clinical manifestation: congenital, intrauterine infection, fetal death, or damage to fetus leading to abnormalities. 5% infants show cytomegalic inclusion body disease. Perinatal, maternal genital secretion or breastfeeding. Postnatal, reactivation, infectious mononucleosis like disease, 8% majority by EBV. Lab diagnosis: H&E stain, large intranuclear inclusions in fibroblasts or epithelial cells of salivary glands, lungs, liver, kidney, pancreas, old eye appearance inclusion inside and cytomegalic cells. Infectious mononucleosis agent: Epstein-Barr virus, atypical lymphocytosis seen, clinical symptoms: fever, myalgia, hepatosplenomegaly, exudative pharyngitis, cervical lymphadenopathy, rashes following ampicillin therapy. Heterophile antibodies elevated, detected by pulmonary test. Specific antibodies to EBV antigens are elevated. Infectious mononucleosis. Epstein-Barr virus causes infectious mononucleosis, also associated with several human tumors in nasopharyngeal carcinoma, Burkitt's lymphoma, Hodgkin disease, B-cell lymphoma. Morphology. EBV member of gamma subfamily of herpesviridae possess double-stranded DNA enveloped with icosahedral symmetry. Expresses three classes of antigens: latent phase antigen, early antigen, late antigen. Pathogenesis. EBV is transmitted by oropharyngeal contact through infected salivary secretions. EBV binds to specific receptors present on B cell, CD21 and CR2, such receptors also present on pharyngeal epithelial cells. Primary infection occurs in oropharynx. EBV replicates in epithelial cells and or surface B lymphocytes of the pharynx and salivary glands. Infected B cells immortalized by virus, large number of variety of immunoglobulins, polyclonal. Many of those are autoantibodies. In response to this, bystander CD8T lymphocytes stimulated and appear a typical feature characteristically seen in infectious mononucleosis. Oncogenicity. Persistent EBV infection induce malignant transformation of infected B cells and epithelial cells by expressing latent EBV antigens LMP and EBNA. Clinical manifestations, also called kissing disease, transmitted through salivary contact or glandular disease, usually affects young adults, not children. Headache, fever, malaise, pharyngitis, cervical lymphadenopathy, hepatosplenomegaly, rashes following ampicillin therapy. Blood, atypical lymphocytosis, CD8 T cells, autoantibodies reactive to sheep RBC antigens detected by pulmonary test. Epstein-Barr virus associated malignancies, Burkitt lymphoma, nasopharyngeal carcinoma, Hodgkin lymphoma, non-Hodgkin lymphoma. Laboratory diagnosis, antibody detection, non-specific heterophile antibody detection, Paul-Bunel test, differential absorption test, monospot test. EBV specific antibody detection, ELISA, and indirect immunofluorescence to detect antibody to viral capsid antigen, EBNA, and early antigen. Molecular methods detects EBV DNA by PCR, quantifies EBV DNA by real-time PCR, detecting genes, detects EBER RNA by RT-PCR, EBV antigen by direct immunofluorescence assay. Treatment of Epstein-Barr virus infection, supportive measure, analgesics for treatment of infectious mononucleosis. Acyclovir treatment of oral hairy leukoplakia reduces EBV shedding from oropharynx. No effect on immortalized B cells. Not effective for infectious mononucleosis and other malignancies. Antibody to CD20, rituximab, effective in some cases. Summary. Epstein-Barr virus diseases, infectious mononucleosis, associated malignancies, nasopharyngeal carcinoma, Burkitt's lymphoma, malignant tumor of lymphoid cells, Africa and New Guinea. Genomic DNA of EBV is present in each B cell. Reactivation prevented, leading to oncogenic potential to be expressed. Nasopharyngeal carcinoma, China, Eskimo, Greenlanders. B cell lymphoma, immunodeficient, transplant and HIV infected, infectious mononucleosis, glandular disease, fever, self-limiting. Disease of young adults. Route of infection, saliva, kissing disease. Incubation period, 4 to 7 days. Fever, sore throat, swollen lymph nodes, and enlargement of spleen and liver. Increased WBC count with absolute lymphocytosis and presence of abnormal or typical lymphocytes in the peripheral blood. Lab diagnosis, Paul-Bunel test. Infectious mononucleosis, heterophile antibodies appear in patient's blood. They agglutinate sheep erythrocytes. Presence of sheep cell agglutination in infectious mononucleosis patients. Doubling dilution of patient serum plus 1% suspension of sheep RBC. Incubation 37 degree, 4 hours. Agglutination titer of 100 or more. Suggestive of infectious mononucleosis.
Hope you find this session useful for your understanding and for your exams. Thank you.